Welcome back to the deep dive. We're here to sift through the complex layers of your source material and pull out exactly what you need for success.
That's right. No filler, just the high-yield critical information.
If you're gearing up for clinicals, studying for boards, or honestly just trying to really get this stuff without drowning in detail, you're in the right place.
Absolutely.
Today we're tackling a big one, assessing the endocrine system.
Yeah.
Chapter 53 specifically, we're going deep on the essential terms, the core physiology, and maybe most importantly, the nursing priorities you absolutely have to know.
Exactly. That's the mission today, the endocrine system. It's like the body's other major communication network right alongside the nervous system. And when things go wrong here, the effects ripple out everywhere fast and systemically.
So we're not just doing a basic overview.
No, definitely not. We're drilling down into the clinical application. We're going to focus really hard on two key concepts that honestly guide almost all nursing interventions in this area.
Which are?
Fluid and electrolyte balance and glucose regulation. These are the big ones for this chapter. Every term, every bit of anatomy, every assessment cue we talk about today, we're going to tie it straight back to these two critical points of stability.
Okay, got it. And our source material, it lays out the science, the foundation, but it really pivots to the action, doesn't it?
It does, and that's what we need. It's not enough to know what, say, aldosterone is. You need to know what happens to your patient if it's too high or too low, and crucially, what you as the nurse need to do about it, like, right now.
So think of this deep dive as us translating that dense physiology into a practical, usable clinical checklist.
Exactly. We have to frame this as a critical assessment guide, not just, a biology lesson. Because spotting an endocrine issue early, it often comes down to noticing subtle signs related to fluid balance or glucose levels.
Things like rapid fluid shifts, or maybe blood sugar that's suddenly unstable.
Nicely. Those priority concepts are the foundation. We need to really understand the hormones controlling them.
Okay, let's start with the language itself. The messengers. If you misunderstand what even one of these key hormones does, well, you can make a wrong assumption about how stable your patient actually is.
Absolutely critical.
Let's begin with the ones that manage our fluid status, the big players there.
Right. Think of this as your essential vocabulary list for fluid management. First up, aldosterone.
Okay, aldosterone. What's the need to know?
Okay, so technically it's a mineralocorticoid. That name tells you it affects minerals, right? Specifically sodium and potassium. Its main job, and this ties directly into that fluid and electrolyte balance concept, is maintaining the volume and the electrolyte makeup of our extracellular fluid.
Right, the fluid outside the cells. And how does it actually do that? What's the mechanism?
It targets the kidneys, specifically the renal tubules. It basically gives them orders, and those orders are two key things. First, reabsorb sodium and water. Pull them back into the bloodstream. That boosts plasma volume.
Okay, increases volume. Makes sense.
Second, and just as important, excrete potassium. Get rid of it. So it's doing both at the same time, holding on to sodium and water, ditching potassium. It's constantly fine-tuning volume and concentration.
And you mentioned it's sensitive.
Oh, highly sensitive. The kidneys follow these orders precisely, which is why, if there's a problem with aldosterone too much or too little, a patient's potassium levels can go haywire really quickly, which immediately impacts the heart.
Okay, so that sensitivity to potassium.
Yeah.
That's a huge nursing flag right there. If you suspect an aldosterone issue, boom, cardiac monitoring is a priority. Risk of hypon or hyperkalemia.
You got it.
All right, moving on. Another key fluid regulator, antidiuretic hormone, or ADH. Also called vasopressin.
Yeah, same hormone, two names. Think of ADH as the body's master water conserver. It's made up in the hypothalamus, then released from the posterior pituitary gland.
And its main job?
Its main job is promoting the reabsorption of just water in the kidney. Unlike aldosterone, which pulls back salt and water, ADH is primarily about managing the concentration of body fluids.
So, like, if you're dehydrated.
Exactly. If you're dehydrated or if your blood osmolarity gets too high, ADH levels shoot up. That tells the kidneys, save every drop of water you can. Make the urine really concentrated.
And if ADH is missing?
Big trouble. The patient loses the ability to concentrate urine. They'll pee out enormous amounts of very dilute urine. We're talking liters and liters. Leads to incredibly rapid, potentially fatal dehydration. That's diabetes insipidus.
Wow. Okay. Let's tackle the hormone that seems to do, well, almost everything.
Yeah.
Cortisol. People call it the stress hormone, but that feels like an understatement.
It really is. Cortisol is the main glucocorticoid, and it's absolutely essential for survival. Its functions are incredibly broad. Yes, it affects the body's stress response. That's the famous part.
But there's more.
Oh, much more. It dictates nutrition metabolism, how we handle carbs, proteins, fats for energy. It's crucial for emotional stability. It helps regulate immune function. And connecting back, it also plays a significant role in sodium and water balance, kind of working alongside aldosterone to keep things stable.
So it's not just stress.
Not at all. If cortisol levels are low, it's a true emergency. The patient basically loses the ability to cope with even minor physical stress. It's profound.
Okay. And then for that immediate, crisis response, the really fast actors, that's the catecholamines, right?
That's your fight or flight crew. Epinephrine and norepinephrine,
Yeah.
released by the adrenal medulla, the inner part of the adrenal gland, when the sympathetic nervous system gets activated.
And the source mentioned a specific ratio.
Yeah, it's about 85% epinephrine, 15% norepinephrine that gets secreted from the adrenal medulla. They get dumped right into the bloodstream and zip around the whole body, causing those widespread effects that get you ready for intense action, immediately.
We also need to talk about the ones setting our internal thermostat, our metabolic pace, the thyroid hormones.
Right. Thyroxine, which is TEX4-4, and triiodothyronine, TEX-2-3. These guys regulate the metabolic rate of pretty much every cell in your body.
Every cell.
It's just about. They influence how much heat you produce, they're vital for brain development, and they directly impact the heart rate, how forcefully it beats, how much blood it pumps out. If thyroid levels are off, the whole body's engine runs either way too fast or way too slow. Big changes in energy, function, everything.
And last but definitely not least, especially for our other priority concept, the key player in glucose regulation, insulin.
Insulin is the gatekeeper for glucose. Its main action is to lower blood glucose levels. It does this by helping glucose move out of the blood and into the cells, where it can be used for energy or stored away.
So it unlocks the cell doors for sugar.
That's a great way to put it. It promotes the movement and storage of carbs, but also protein and fat. If you don't have enough insulin, or if your cells stop responding to it properly, insulin resistance, glucose just builds up in the blood. That leads straight to the classic signs of diabetes.
Okay, so we have this powerful team of chemical messengers, but the body is huge. How do these hormones know where to go? How do they deliver their message only to the right place? That brings us to the target principle, right?
Exactly. It's a really elegant system. Hormones circulate everywhere, but they don't just cause chaos. They only work on specific tissues called target tissues.
And the source uses that log and key analogy, figure 53.2. Let's break that down, because it explains not just how hormones work, but why problems can happen even if the hormone level itself seems okay.
Perfect. So think of the hormone as the key. For that key to actually do something to change a cell's activity, it has to fit perfectly into a specific lock. That lock is the receptor site.
Where are these receptors?
They can be on the surface of the target cell or sometimes inside it. And here's the critical part. That receptor site, that lock, is usually specific for only one type of hormone.
So hormone A fits the hormone A receptor, but hormone B bounces right off.
Precisely. It ensures the message gets delivered only where it's intended. Super specific communication.
Which means a problem isn't always about not having enough keys, not having enough hormone. What if the lock itself is broken? Or maybe there just aren't enough locks.
That's exactly it. That's the third big category of endocrine problems, and it's so important for you to grasp, especially thinking about type 2 diabetes. You can have hormone excess, hormone deficiency, or poor hormone receptor interactions.
Meaning the target tissue just isn't listening.
Right. The receptor, the lock might be damaged, or maybe the cell has reduced the number of receptors it displays, something called downregulation. In that case, the key, the hormone, is there, maybe even in high amounts, but it can't unlock the door.
So clinically, it looks like a deficiency, even if the hormone levels are normal or high.
Exactly. That's the core concept behind insulin resistance in type 2 diabetes. The insulin is there, but the cells aren't responding to it effectively. Understanding this receptor issue is fundamental.
Which leads us nicely into how the body actually manages this whole complex system to keep everything stable.
Right. So the endocrine system is basically the body's master regulator for homeostasis, keeping everything in balance. It's controlling metabolism, growth, nutrition, elimination, fluid and electrolyte balance, reproduction. You name it. It has to constantly monitor the internal environment and adjust its chemical signals to keep things optimal.
And the main tool it uses to maintain this balance, this stability, is the negative feedback mechanism. This sounds technical, but understanding this loop is really the key to figuring out why glands secrete hormones when they do, and crucially when they stop.
It does sound complex, but the core idea is actually quite simple. The result of the hormone's action is always negative or opposite to the thing that triggered its release in the first place.
Okay, say that again slightly differently.
The formal definition is a negative feedback mechanism signals an endocrine gland to secrete a hormone in response to some change in the body. The hormone causes a reaction that opposes that initial change, pushing things back towards normal, back to homeostasis.
Let's use the simple example from the text. Insulin secretion. How does that fit the negative feedback rule? Walk us through it.
Okay, so imagine you just ate a meal, maybe lots of carbs. Your blood glucose level starts to rise above the normal range. That rise in glucose is the initial change, the stimulus.
Got it. Blood sugar's going up.
The pancreas detects this rise and responds by secreting insulin. Now, what does insulin do? Its action is to help glucose get into cells, which lowers the blood glucose level.
Ah, okay. So the stimulus was high glucose.
Mhm.
The result of the hormone action is lower glucose. The result is opposite or negative
Yeah.
to the stimulus.
Exactly. And once the blood glucose level returns to the normal range, that return to normal signals the pancreas, okay, job done, you can ease up on the insulin now. The system basically turns itself off.
So it's this constant adjustment, keeping things in a tight range.
Precisely. That's why in healthy people, blood sugar stays relatively stable despite meals, fasting, exercise, whatever.
Okay, that's the straightforward one-gland example. But it gets trickier with the multi-gland pathways, right? That's where diagnosis can get complicated. Let's tackle the more complex example, cortisol regulation. Figure 53.3 shows this involves the hypothalamus, the pituitary, and the adrenal glands, the HPA axis.
Right, this is a classic three-tier system, and it's absolutely vital, especially for managing stress. We need to trace the cascade of signals. It all starts when the body senses that the levels of the final hormone, cortisol, are too low.
Okay, step one. Low cortisol is detected. This signals the hypothalamus in the brain. What does it do?
The hypothalamus releases corticotropin-releasing hormone, or CRH. Think of CRH as the initial alert signal, the wake-up call.
Okay, CRH is released. Where does it go?
It travels just a short distance down to the anterior pituitary gland.
And that's step two. What happens at the pituitary?
CRH tells the anterior pituitary, release your hormone. So the anterior pituitary releases adrenocorticotropic hormone, or ACTH. ACTH is called a trophic hormone because it feeds or stimulates its target gland. It's the command signal sent out to the field,
And ACTH travels through the bloodstream to its target.
which is the adrenal cortex, the outer layer of the adrenal gland sitting on top of the kidney. That's step 3.
So ACTH arrives at the adrenal cortex. What's the command?
ACTH tells the adrenal cortex, make and release cortisol. So the adrenal cortex starts pumping out cortisol. As cortisol levels in the blood begin to rise, this rising level is monitored by the system, and this is where the negative feedback comes in to shut things down.
Okay, focus on the shutdown. The rising cortisol acts as the brake. Where does it apply the brakes?
It travels back up the chain. High levels of cortisol circulate back to both the hypothalamus and the anterior pituitary.
And tells them what?
It basically says, okay, we have enough cortisol now, you can stop sending the make more signals. So high cortisol it stops the release of CRH from the hypothalamus, and it inhibits the release of ACTH from the anterior pituitary.
So it cuts off the stimulation at the source.
Exactly. No more CRH means no more ACTH stimulation. No more ACTH means the adrenal cortex stops making extra cortisol. Cortisol secretion then drifts back down to its normal baseline level. It's a self-regulating loop designed to prevent having too much or too little cortisol.
This really highlights why figuring out endocrine problems can be tricky for everyone involved, nurses included. Like if a patient has high cortisol levels, Cushing syndrome, the nurse knows the problem might be in the adrenal gland itself just overproducing on its own. That's a primary problem.
Right.
Or the problem could be higher up. Maybe the pituitary is pumping out too much ACTH, constantly telling the adrenals to make more cortisol. That's a secondary problem.
And making that distinction is crucial in practice. If you do the tests and find the patient has high ACTH and high cortisol, the issue is likely upstream in the pituitary or even the hypothalamus. It's a central issue.
But if cortisol is high and the ACTH is actually low,
Then the adrenal cortex is acting rogue. It's ignoring the feedback and overproducing cortisol all by itself. That's a primary peripheral problem. Understanding this feedback system literally guides the entire diagnostic workup.
and like the source material points out, this whole intricate system can fail in different ways, leading back to those three main types of endocrine problems: hormone excess, hormone deficiency, or those receptor problems where the tissues just don't respond right.
Okay, now we need to really zero in and connect these hormones directly to our two big priority concepts,
Hmm.
fluid and electrolyte balance and glucose regulation, because these are the areas where nurses take immediate, often life-saving action.
Let's start with fluid and electrolyte balance. We talked about aldosterone coming from the adrenal cortex. What specifically triggers the body to release more aldosterone? What kicks off that process?
The main driver is the renin-angiotensin-aldosterone system, usually called the RAAS. That's the big one. Secondary triggers are the level of potassium ions in the blood, and to a smaller degree, ACTH can also stimulate it.
Okay, focus on the RAAS. When does that system get activated?
The RAS kicks in whenever the body senses its fluid volume is low. Think things like low blood pressure, decreased blood flow getting to the kidneys, or maybe significant sodium loss like from sweating or vomiting.
So a patient comes in hypotensive. The kidneys sense this decreased perfusion.
Hmm.
What happens next? How does that lead to aldosterone release?
Right, the kidneys sense the low pressure and release an enzyme called renin. Renin starts a cascade. It converts a protein called angiotensinogen, which is always floating around, into angiotensin the first.
Okay, renin makes angiotensin the first. Then what?
Angiotensin I then gets converted into angiotensin the second, mostly by an enzyme in the lungs. And angiotensin the second is powerful stuff. It's a potent vasoconstrictor. It squeezes blood vessels to raise blood pressure directly, and it travels to the adrenal cortex and tells it, release aldosterone.
Wow, okay. So it's a rescue mechanism to boost volume and blood pressure.
Exactly. It's a compensatory cascade. And the nurse needs to understand that the result of that aldosterone release holding on to sodium and water, dumping potassium, is the body's aggressive attempt to fix the fluid and electrolyte problem.
So if this RAS system goes haywire, or if the adrenal gland itself is malfunctioning, what's the immediate danger for the patient? Let's talk hyperaldosteronism first. Too much aldosterone.
Okay, with hyperaldosteronism, the patient reabsorbs way too much sodium in water. This often leads to volume overload, edema, and definitely hypertension. But critically, they're also excreting huge amounts of potassium, so severe hypokalemia is a major risk.
And hypokalemia means?
Means the patient is at immediate risk for dangerous cardiac dysrhythmias like PVCs or even worse, and also significant muscle weakness.
Okay. What about the flip side? Too little aldosterone and hypaldosteronism.
Then you get the opposite picture. The patient can't hold on to sodium and water effectively, so they risk volume depletion, low blood pressure, maybe even shock. And crucially, they retain potassium because they can't excrete it. So hyperkalemia is the big electrolyte danger here.
And hyperkalemia is also a cardiac emergency.
Absolutely. Can lead to bradycardia, heart block, even cardiac arrest. The source material mentions that aldosterone responds to potassium changes as small as 0.1 MEQL. That tells you how incredibly tight this regulation is and how dangerous imbalances can be. So monitoring the EKG and potassium levels is non-negotiable.
Okay, that really drives home the fluid and electrolyte connection. Now let's loop back to cortisol. We know it's the stress hormone, but the source lists functions in box 53.1. Why is cortisol so important for maintaining sodium and fluid balance too, even though it's mainly a glucocorticoid?
Cortisol has what we call a permissive effect. Basically, lots of other bodily processes, including other hormones, need cortisol to be present to work properly. Regarding fluid balance, it does have some weak mineralocorticoid-like activity, helping retain sodium. But its bigger role comes from maintaining overall systemic stability, especially during stress.
Explain that stability part more.
Remember, it manages the body's response to stress. If cortisol levels plummet, like in an Addisonian crisis, the patient simply cannot cope. They become profoundly hypotensive, their blood vessels can't constrict properly, and their whole cardiovascular system starts to collapse.
And the source mentioned something striking. Cortisol is needed for normal heart muscle cell excitability. Why is that?
It ties into the catecholamines. Cortisol needs to be present for epinephrine and norepinephrine to have their full effect on the heart and blood vessels. If cortisol is severely depleted, even if the body releases adrenaline, the heart muscle cells and blood vessels don't respond effectively.
So the fight or flight system fails.
Essentially, yes. The patient loses the ability to mount an adequate sympathetic response. That's why severe cortisol deficiency leads to refractory shock, shock that doesn't respond well to fluids or standard vasopressors, and cardiovascular collapse. It elevates cortisol deficiency from just a chronic problem to an acute, life-threatening emergency. You need to give fluids and cortisol hydrocortisone immediately.
Wow. That connection really underscores why maintaining cortisol levels or replacing them aggressively in a crisis is a critical nursing priority. Okay, let's pivot to our second major concept, glucose regulation.
Right. Here again, cortisol plays a key role, but this time as a counter-regulatory hormone. Its job in glucose metabolism is actually to prevent hypoglycemia, low blood sugar.
How does it do that?
Two main ways. First, it stimulates the liver to make new glucose from sources like amino acids and fats. That process is called gluconeogenesis. Second, it makes peripheral tissues, like muscles, a bit resistant to insulin, so they use less glucose.
So it's raising blood sugar, essentially.
Yes, it ensures that even during fasting or under intense stress, the brain, which relies heavily on glucose, gets a continuous supply of fuel. It also promotes lipolysis, breaking down fat for alternative energy. That's why prolonged high cortisol, like in Cushing's, often leads to hyperglycemia.
Okay, but the primary regulators of moment-to-moment blood sugar,
Uh-huh.
those are in the pancreas, right? The islets of Langerhans.
Exactly. Inside those islets, you've got several crucial cell types. The alpha cells make glucagon. Glucagon's job is to raise blood glucose, mainly by telling the liver to break down its stored glycogen. That's glycogenolysis.
Okay, glucagon, glucose goes up.
Then you have the beta cells. They make insulin. Insulin's job, as we said, is to lower blood glucose by helping it get into cells for use or storage.
Insulin glucose goes down. It's a push-pull system.
Precisely.
Up.
And there's a third type, the delta cells. They make somatostatin. Think of a somatostatin as like a local referee or dimmer switch. It inhibits the release of both glucagon and insulin, helping to fine-tune the balance between them.
So it's this constant interplay between insulin and glucagon that keeps our blood sugar in that narrow, healthy range most of the time. But what happens in a crisis? When the body needs a sudden, massive surge of energy, that's where the catecholamines jump back in, isn't it?
Absolutely. This is where the nervous system, sympathetic activation, and the endocrine system, adrenal medulla releasing epinephrine or epinephrine, work together seamlessly. Catecholamines are emergency glucose mobilizers. They flood the body to provide instant fuel.
And they do this by binding to specific receptors, right? The source mentions alpha and beta adrenergic receptors.
Yep. These receptors are found on target tissues all over the body. The specific type of receptor determines the effect.
Table 53.2 in the source details some of these effects. Let's walk through how this translates into things a nurse would actually see or assess in a patient having a major stress response.
Okay, good idea. Let's trace the effects. In the heart, catecholamines hit beta-1 receptors. The result: increased heart rate, stronger contractions, more blood pumped out. Clinically, you assess this as tachycardia, maybe a bounding pulse.
What about blood vessels? Vital for blood pressure in a crisis.
In the blood vessels, it's a bit more complex. Alpha receptors are widespread and cause vasoconstriction, tightening of the vessels. This shunts blood towards the vital organs and drives up blood pressure. It can also make the patient look pale, feel cool or clammy.
But there are beta receptors in vessels too.
Yes, beta-2 receptors are found in the blood vessels supplying skeletal muscle, the heart, and the lungs. Catecholamines hitting these beta-2 receptors cause vasodilation there, ensuring those crucial areas get more blood flow for fight or flight. So it's a redirection of blood.
And breathing. We need more oxygen for all this activity.
Right. Beta-2 receptors are also in the bronchioles of the lungs. Stimulating them causes the airways to relax and dilate, making it easier to get more air in. That bronchodilation is a direct catecholamine effect.
Okay, finally, link it directly back to glucose. How do catecholamines actually get more sugar into the blood?
This is key for our glucose regulation concept. In the liver and also in fat cells, catecholamines hit both alpha and beta receptors. The effect is a dramatic increase in gluconeogenesis, making new sugar, and glycogenolysis, releasing stored sugar from the liver.
So they're shouting, release the sugar, make more sugar.
Pretty much. And at the same time, they ramp up lipolysis, breaking down fat into fatty acids that can also be used for energy. This is why intense stress or conditions like a pheochromocytoma, a tumor releasing excess catecholamines, cause hyperglycemia and a hypermetabolic state. The body is just pouring fuel into the system.
It's this massive, coordinated response designed for survival. But if any part of it is excessive or deficient, you see this dramatic multi-system fallout, which of course brings us right to what the nurse needs to look for during assessment.
Right. And because endocrine disorders often creep up slowly, the nurse needs incredibly sharp assessment skills, both in taking a detailed history and in performing a thorough physical inspection. Spotting the subtle clues early is often the whole game.
Before we dive into the specific physical signs, let's quickly touch on that crucial health equity note about type 2 diabetes.
Yes, this is really important context for nursing practice today. The source reminds us, based on CDC data, that type 2 diabetes isn't distributed evenly. It disproportionately affects people from certain racial and ethnic minority groups, and also people with lower socioeconomic status.
So our role goes beyond just bedside care.
Absolutely. We have to be advocates. This means really focusing our health teaching, our screening efforts in communities that are at higher risk. We need to work to make sure that early diagnosis and intervention are actually accessible, not just theoretically available. It involves tackling barriers related to diet, stress, education, access to healthy food, safe places to exercise, and affordable health care.
A vital point. Okay, now let's get practical. The patient history questions in box 53.4, the source calls them the big 7 areas that can point towards a hormone imbalance. Let's go through them, but really connect why we're asking each one.
Good plan. The first one seems simple, but it's huge. Energy level changes. Asking about fatigue or, conversely, excess energy. Why is this so telling?
Well, energy is metabolism, right?
Exactly. Your overall energy level is heavily influenced by your thyroid hormones and cortisol. If a patient reports this profound ongoing fatigue, like way beyond just being tired, almost lethargic, you should immediately think about hypothyroidism, low thyroid, or maybe hypocortisolism, adrenal insufficiency, Addison's disease.
And the opposite, feeling wired.
Yeah. If they report feeling constantly agitated, restless, maybe shaky, like they've had way too much caffeine, that points towards hyperthyroidism, overactive thyroid. The key is asking, is this new? Is it persistent? How different is it from your usual energy?
Okay. Tied closely to energy and metabolism is question 2, temperature tolerance. Changes here can be really subtle, but very informative.
Definitely. If someone complains of always being hot, sweating easily, can't stand warm rooms, even when others are comfortable, that screams hypermetabolism, most likely hyperthyroidism.
And if they're always cold.
Constantly feeling chilled, needing sweaters or blankets when others are fine, maybe even noticing their skin feels cool, that suggests hypometabolism, probably hypothyroidism. It's a simple question. How's your tolerance to heat and cold changed? But it gives you a direct clue about their metabolic rate.
Okay, number 3 covers sleep and hair distribution changes. How do these relate?
Sleep patterns like sudden onset of insomnia or maybe sleeping excessively, somnolence, can be linked to thyroid issues or disruptions in the normal daily rhythm of cortisol release. Our sleep-wake cycle depends on these hormonal fluctuations being normal.
And the hair changes.
Hair changes are classic signs. Unexplained hair loss can happen with thyroid problems, but maybe more strikingly, the development of hirsutism, that's excess, coarse hair growth in women in places where men typically grow hair, like the face, chest, or back points, strongly towards an excess of androgens, male-type hormones, which could come from the ovaries or the adrenal glands. Any significant change in hair amount or distribution needs careful documentation. Where is it? When did it start?
4th area, physical structure, specifically facial contour or eye protrusion. What are we looking for?
We're looking for changes over time. Does the patient report, or do you notice maybe a more prominent forehead, an enlarging jaw, coarser facial features? That could suggest acromegaly caused by excess growth hormone from the pituitary, usually developing slowly over years.
And the eye protrusion, that's pretty specific.
Very specific. That's exophthalmos. The eyeballs appear to bulge forward, and the upper eyelids might look retracted, giving a staring appearance. This is most commonly associated with hyperthyroidism, particularly Graves's disease. It's caused by swelling and tissue buildup behind the eyes. If you see this, you must assess for eye dryness, irritation, or vision changes because the cornea is at risk.
Good point. 5th clue, a change in voice quality. How might that relate?
An unexplained change, like persistent hoarseness or a deepening of the voice, especially in women, can sometimes be a sign of thyroid enlargement. A goiter possibly pressing on nearby structures like the trachea or the nerve that controls the vocal cords. Or it could be related to androgen excess. It definitely warrants further investigation.
Okay, the last 2 history questions tie directly back to our priority concepts: urinary changes and reproductive changes.
Yes, big ones. Any report of major urinary changes, like having to pee constantly, frequency, passing huge volumes of urine, polyuria, or being intensely thirsty all the time, polydipsia, should make you think immediately about 2 main possibilities. Problems with ADH, leading to diabetes insipidus, or, much more commonly, poor glucose regulation due to diabetes mellitus, high blood sugar spilling into the urine and pulling water with it.
And reproductive changes.
For women, asking about changes in menstrual cycles, irregular periods, missed periods, heavy bleeding. For both men and women, asking about changes in libido or fertility issues, these point directly towards potential imbalances in the sex hormones, estrogen, testosterone, or the pituitary hormones that control them, LH, FSH. Sometimes adrenal problems can also affect sex hormone levels.
Okay, that covers the key history questions. Now let's shift to the hands-on physical inspection. Beyond the facial features we mentioned, what visual cues are important?
We need to look carefully at the skin and the way fat is distributed on the body. The skin can tell you a lot. Look for areas of hypopigmentation, particularly vitiligo. These are smooth, white patches where the skin has lost pigment. Vitiligo is sometimes associated with autoimmune conditions that can also attack endocrine glands, especially the adrenal glands causing primary adrenal insufficiency, Addison's.
And the opposite, darker skin?
Right, look for hyperpigmentation. This often appears as a diffuse tanning or bronzing of the skin, especially in sun-exposed areas, but also characteristically in skin creases, like the palms, over elbows and knees, and sometimes on the gums or inside the cheeks. This can be a sign of very high levels of ACTH.
Why does high ACTH cause darkening?
Because the precursor molecule for ACTH also contains a sequence called melanocyte-stimulating hormone, MSH. When ACTH production is chronically high, like when the adrenal glands aren't working and the pituitary is screaming for cortisol, MSH levels go up too, stimulating pigment production. It's a classic sign of Addison's disease.
Fascinating. Okay, what about fat distribution? These are some classic hallmark signs, aren't they?
Absolutely classic, especially for excess cortisol, Cushing's syndrome. You look for truncal obesity where fat accumulates mainly around the abdomen, chest, and upper back, while the arms and legs might remain relatively thin.
And the famous buffalo hump.
Yes, that's the accumulation of fat specifically on the back of the neck and between the shoulders. That, combined with truncal obesity and often a rounded moon face, plus maybe those purplish stretch marks on the abdomen, breasts, or thighs, that whole picture strongly suggests excess adrenocortical hormones. The cortisol is literally rearranging where the body stores fat.
Okay, let's talk specifically about assessing the thyroid gland in the neck. What's normal, and what do we do if we suspect it's enlarged?
Normally, when you just look at the neck, you shouldn't be able to see the thyroid gland. It's usually quite small and sits low in the front of the neck. We often ask the patient to swallow some water. If the gland is enlarged, a goiter, you might see it move up and down more prominently.
So if you do see a visible enlargement, what's the very next step before touching anything?
Auscultate. Listen over that enlarged area with the bell of your stethoscope.
Why auscultate first? What are you listening for?
You're listening for a brute. A brute is this rushing, whooshing sound like turbulent blood flow. In the thyroid, a brute means the gland is hypertrophied, it's enlarged, and has way more blood flowing through it than normal. This is often seen in hyperthyroidism.
And finding a brute has major safety implications, right?
Huge implications. It signals a hyperactive, highly vascular gland, and that leads directly into the major safety alert we need to hammer home later. If you hear a brute, palpation becomes much riskier.
Okay, really important sequence. Inspect, then auscultate if enlarged, then consider palpation carefully based on findings and context.
Got it. Finally, let's talk about the effects of aging, using that patient-centered care box from the source. These changes are critical because they can so easily be brushed off as just getting older, potentially delaying diagnosis of a real endocrine problem.
Absolutely. We need to highlight 3 key age-related changes and the nursing considerations for each. First, older adults often have decreased ADH production.
Less ADH means, what's the consequence? It means their kidneys don't concentrate urine as well. Their urine tends to be more dilute, even if they haven't had much fluid. On top of that, the sensation of thirst often becomes less reliable with age.
So the risk is?
Dehydration and high sodium levels, hypernatremia. The nursing consideration is critical. You have to assess their fluid status much more frequently, check skin turgor, mucous membranes, urine output, vital signs. And you often need to proactively encourage them to drink fluids, even if they don't feel thirsty. Don't wait for them to ask.
Okay, second age-related change, decreased glucose tolerance.
Yeah, this is common. As people age, their pancreas might secrete slightly less insulin, and perhaps more importantly, their body cells can become somewhat less sensitive to the insulin they do produce.
So even if they're not overweight, their blood sugar might run a bit higher.
Exactly. They might have slightly elevated fasting blood sugar, or their sugar might spike higher after meals and take longer to come back down. The danger here is that the early symptoms of type 2 diabetes, like slow wound healing, maybe recurrent yeast infections, sometimes increased thirst or urination, get dismissed. Oh, that's just part of aging.
So the nursing consideration here is,
Vigilance and education. Teach the importance of staying active and eating healthily, as that helps maintain insulin sensitivity, but also maintain a high index of suspicion. If an older patient presents with things like wounds that just won't heal or persistent fungal infections, you need to check their blood sugar. Don't just assume it's age. And the third key change is a general decreased metabolism.
often due to thyroid changes.
Yeah, thyroid hormone production might decrease a bit, or the body's tissues might not respond as well to it. The result is that everything just slows down.
So they might feel colder, have less appetite.
Right. Less tolerance for cold environments, maybe a decrease in appetite, sometimes a slower heart rate, maybe lower blood pressure.
And the nursing consideration. Again, don't just chalk it up to age.
Exactly. You need to provide comfort measures, like teaching them to dress in layers to stay warm. But more importantly, you have to carefully assess for signs that might indicate an actual endocrine disorder masquerading as aging. Things like persistent, significant lethargy, new onset constipation that doesn't resolve, noticeable declines in cognition, a consistently low body temperature, or a heart rate that's always below 60 beats per minute. These aren't just normal aging, they warrant a full endocrine workup.
Okay, let's really cement this clinical knowledge now by looking at how it applies in high-stakes situations, like exam questions or critical patient scenarios. The source gives us two NCLEX challenge questions that nicely summarize some key priorities.
Yeah, these are good for focusing or thinking. The first one, you have an older adult female patient who's had 2 bone fractures in the last year. Which lab value is the priority for the nurse to monitor? The options are cortisol, Dusty-543, and calcium.
Okay, recurrent fractures in an older woman, you immediately think bones. So the priority lab has to be calcium, right? Why is that the most direct endocrine link here?
Because calcium balance is intimately tied to bone health, and it's tightly regulated by hormones, mainly parathyroid hormone, PTH, from the parathyroid glands, and calcitonin from the thyroid gland.
Remind us what PTH does.
PTH increases serum calcium levels. One way it does this is by stimulating bone resorption, basically, breaking down bone tissue to release calcium and phosphate into the blood. While necessary, if PTH is chronically high, it can weaken bones over time. Calcitonin does the opposite. It lowers serum calcium, partly by inhibiting bone resorption.
So in an older person with fractures, checking their serum calcium levels is the first step in assessing if there's an underlying metabolic bone issue, possibly related to PTH problems like hyperparathyroidism or maybe vitamin D deficiency, which also affects calcium. It's the most direct link among those options. Okay, second scenario. A 42-year-old client comes in for assessment of a possible endocrine problem. Which of these findings requires further assessment most urgently? The choices are a visible thyroid gland, the fact they wear bifocals, a receding hairline, or recent weight loss.
Well, bifocals and a receding hairline are pretty common changes, especially at 42. Recent weight loss could be significant, but it's nonspecific, could be many things. But the finding that absolutely demands immediate further investigation is the visible thyroid gland upon inspection.
Because, as we said earlier,
Because a normal thyroid gland usually isn't visible just by looking at the neck. If you can see it, that means it's enlarged, it's a goiter. That is a direct, objective physical sign pointing towards a potential thyroid abnormality. It's the most significant and specific endocrine clue among those choices and requires immediate follow-up, starting with auscultation.
perfect. And that discussion leads us straight into the single most critical safety alert in this whole deep dive, the nursing safety priority. Action alert about thyroid palpation. Can you state that rule clearly?
Absolutely. This is one you just have to memorize and never violate. Avoid applying pressure or palpating the thyroid gland in any patient who either has diagnosed hyperthyroidism or is even suspected of having hyperthyroidism.
Why is palpating feeling the thyroid so dangerous in this situation? What catastrophic event are we trying to prevent?
We are trying to prevent something called a thyroid storm or thyrotoxic crisis. It's a rare but life-threatening emergency.
How does palpation trigger it?
If the thyroid gland is already hyperactive and potentially enlarged, like if you saw it or heard a brute, physically manipulating it, pressing on it, feeling it firmly can cause the gland to suddenly dump a massive amount of preformed thyroid hormones right into the bloodstream all at once.
And that sudden hormone overload causes
Causes extreme hypermetabolism. The patient develops severe hyperthermia, very high fever, extreme tachycardia, dangerously fast heart rate, severe hypertension, often arrhythmias, heart failure, agitation, delirium. It can be fatal if not recognized and treated immediately and aggressively.
So the rule is inspect, auscultate if enlarged. But do not palpate if hyperthyroidism is known or suspected. Wait until the situation is clarified or the patient is stable.
That is the absolute rule. It's a nurse-driven safety measure that protects the patient from a potentially lethal complication.
Okay, point taken.
Right.
Let's wrap up by talking about the nurse's crucial role in diagnostic testing. Getting these hormone tests right is essential, and the collection process can be finicky.
It really can be. Hormones and their breakdown products, metabolites, are measured in blood, urine, sometimes saliva. For blood tests, often called assays, the nurse needs to be super careful about handling the sample, storing it correctly, and avoiding contamination. You always need to check the lab manual for specific requirements before you draw the blood.
The source gives a really specific, high-alert example about sample handling. Which one was that?
The catecholamines, epinephrine, and norepinephrine. These hormones break down really fast at room temperature. So the blood sample must be collected in a special chilled tube, placed immediately on ice, and rushed to the lab right away. Any delay or warming can give you a falsely low result.
What about drawing from an existing IV line? Any special precautions?
Yes, absolutely critical. If you're drawing from an IV line, you have to flush it thoroughly according to your facility's protocol, often discarding the first few milliliters of blood drawn. Why? Because any residual IV fluid or medication or even heparin from the line flush can dilute your sample or interfere with the test, giving you a completely inaccurate result. Could lead to misdiagnosis or wrong treatment. Timing of the draw relative to medication administration is also often critical. Precision matters.
Okay, good points. Now let's talk about the test that probably requires the most patient instruction, the 24-hour urine collection. This seems easy to mess up if the instructions aren't perfect.
Oh, it's very easy to mess up, and if it gets messed up, you've wasted 24 hours and have to start over. This test gives a great overall picture of hormone production over a full day, much better than a single snapshot blood test for some hormones like cortisol metabolites or catecholamines.
So what are the key instruction points for the nurse to give the patient?
First, check if the specific test requires a preservative in the collection jug. Some do, and these preservatives can be strong acids or chemicals, so the patient needs to be warned. Be careful, don't splash this, don't touch it.
Okay, preservative check. Then the actual collection process.
The collection starts by having the patient empty their bladder completely and discard that first urine specimen. Note the exact time. Let's say it's 7:00 a.m. That 7:00 a.m. is the official start time of the 24-hour collection.
Discard the first one, note the time. Got it. What happens from then on?
From that moment forward, for the entire next 24 hours, the patient must save every single drop of urine they produce. They need to collect it all in the special container provided. They should be instructed to void into a clean collection hat or urinal first, then pour it into the main jug, especially if there's a preservative they shouldn't touch. They need to remember to collect urine before having a bowel movement so none is accidentally lost.
And how does the collection end?
Exactly 24 hours after the start time. So in our example, at 7 a.m. the next morning, the patient needs to empty their bladder one last time, even if they don't feel the urge, and add that final specimen to the collection jug. That concludes the 24-hour period.
And if they miss even one void during that time?
The entire test is invalid. They have to discard everything and start all over again another day. It's crucial they understand that. Also, check if the specimen needs to be kept refrigerated or on ice during the collection period. The nurse needs to instruct them on how to do that properly.
Okay, crystal clear instructions are key there. Finally, the specialized tests, provocative and suppression tests. When would these be ordered?
These are used when the baseline hormone levels are kind of ambiguous, maybe borderline, maybe normal, but the clinical picture still strongly suggests an endocrine problem. These tests are designed to push the system to see how it responds under stimulation or suppression.
Okay, so provocative tests, also called stimulation tests, these are for suspected underactive glands, right? Hypofunction.
Exactly. Think of it like a stress test for that specific gland. You give the patient a substance that should normally stimulate that gland to produce its hormone. For example, you might give synthetic ACTH, cosyntropin, to test the adrenal cortex's ability to produce cortisol.
And what are you looking for?
You measure the hormone level before and after the stimulus. If the gland is healthy, the hormone level should rise significantly, hitting a certain target. If the hormone level fails to rise adequately after the stimulation, it confirms that the gland is underactive. It confirms hypofunction. The nurse needs to monitor the patient during these tests, as giving the stimulating agent can sometimes cause temporary side effects.
Makes sense. And suppression tests are the opposite logic. Use when you suspect an overactive gland, hyperfunction, and hormone levels might already be high or high normal.
Correct. This is like testing the gland's brakes. You give the patient a substance that should normally suppress or turn off the production of that hormone via the negative feedback loop.
Example.
The classic example is the dexamethasone suppression test for suspected Cushing's syndrome. Dexamethasone is a potent synthetic cortisol. Giving a dose should tell the normal pituitary gland, whoa, lots of cortisol around, stop making ACTH, which should then cause the adrenal glands to stop making cortisol.
And if the levels don't get suppressed,
If the hormone level, cortisol in this case, fails to suppress like it should, it indicates that the gland, or the HPA axis, is functioning autonomously. It's ignoring the normal feedback signals. It confirms hyperfunction. The gland's brakes aren't working. #outro.
wow, okay, we've definitely taken a deep dive today. We've pulled out the absolute must-know information for assessing the endocrine system. We nailed down the roles of those key hormones, aldosterone, ADH, cortisol, insulin, especially tying them back to fluid balance and glucose control.
Yeah, and we really unpacked that negative feedback concept, both simple and complex examples, because understanding that is fundamental to figuring out what might be wrong.
And we translated those textbook descriptions into actual clinical signs. Nurses need to spot things like the buffalo hump, that truncal obesity pattern, exophthalmos, the skin changes like vitiligo or hyperpigmentation. These are the visual cues.
Absolutely. And the essential takeaway, I think, for anyone listening, especially if you're a student or new to this area, is that unbreakable link between your assessment findings and your priority interventions. You have to constantly be thinking, what does this finding mean for my patient's fluid and electrolyte balance? What does it mean for their glucose regulation?
And remembering those critical safety points.
Definitely. Like the potential catastrophe of thyroid storm, which makes that no palpation rule for suspected hypothyroidism completely non-negotiable. And also just the importance of meticulous technique with history taking and specimen collection. Getting those right impacts everything downstream.
Our source material also really emphasized getting a comprehensive history, including asking about all medications, supplements, even things like steroid use for bodybuilding, because these external factors can seriously mess with the body's delicate hormonal balance.
That's a huge point. The endocrine system is built on these intricate feedback loops designed for internal balance. Throwing external hormones into the mix, whether prescribed or not, can disrupt things profoundly, and sometimes those disruptions take a long, long time to resolve.
Which brings us to a final thought for you, the listener, to kind of chew on as you integrate this knowledge into your practice. We know the endocrine system relies on this incredibly fine-tuned balance. We also know that many people self-treat with over-the-counter supplements, hormones, or fitness aids, often without fully understanding the potential impact.
Yeah, that's increasingly common.
So here's the question. Given how sensitive this system is, could providing thorough, proactive patient education about the potential risks of common supplements, the impact of lifestyle choices like chronic stress or extreme exercise regimens, could that kind of education actually be one of the most powerful initial nursing interventions we have for preventing future endocrine dysfunction in the first place?
That's a really interesting point. Shifting focus upstream to prevention through knowledge, if patients understand how easily this balance can be tipped.
Exactly. Empowering them to protect that balance themselves. Something to think about.
Definitely food for thought.
Okay, that wraps up our deep dive for today. We hope this helps you master the essentials of endocrine assessment. We'll catch you on the next deep dive.